March 8th, 2021 COVID clinical care rounds focused on EMS patient care and operations. I'm John Kramer. I'm an emergency and an EMS physician. I'm the director of the Office of EMS at the National Highway Traffic Safety Administration and the team lead for the COVID-19 EMS pre-hospital team. I'm also the EMS medical director for the Caroline County, Maryland Department of Emergency Services. The purpose of these sessions is peer-to-peer real-time sharing of COVID-19 EMS challenges and successes. In developing these sessions, our guiding principle is if I'm preparing my EMS system for COVID-19 patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who are collaborating in this series. It is not intended to be redundant or replace any organization's initiatives. It is intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Strominger and his fantastic team for the peer-to-peer learning platform that we're using for these rounds. Upcoming ECHO clinical COVID-19 rounds are typically all noon Eastern time US. EMS obviously focuses on, Monday obviously focuses on EMS issues. Tuesday, critical care rounds. Thursday, emergency department rounds. And we have a special series ongoing currently on Wednesdays, looking at outpatient therapeutics issues. Special appreciation to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support of these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. We continue to receive many questions for each of these rounds and apologize in advance that we're not able to answer all of them. But we do select major themes and individual questions from those received and hope to cover them either during this session or upcoming sessions. We'll also be doing crowdsourcing and polling questions with the results shown in real time so that we all have the opportunity to learn together. I'd now like to turn it over to Dr. Strominger to review some of the logistics and other information. Bruce.
Thank you, John, and welcome everyone, particularly to the nearly 200 participants from across the country and around the world joining us today, and special thanks to our guest presenters and our panelists joining us. So as John said, I'm just going to run through a few housekeeping items. Most important, we really want your questions and hope to get to as many of them as we can. So please put those in the Q&A feature. It's at the bottom right of the Zoom toolbar. If you have any technical or logistic issues, mention those in the chat. We'll be monitoring that and try to help you out as best we can. We are recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. Today's presentations will be shared along with the recording on our COVID-19 Clinical Rounds website. We'll share a link to that. They should be up on the website within a day or two. The presentations probably were also shared in the announcement that went out today if we had them available. And we will be offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. That link should be on the announcement that went out today. We'll also share it in the chat about 15 minutes before the end of the session, and you'll have 48 hours to complete the 2 to 3 minute survey that's anonymous, and then you'll be able to get your instant certificate. We really appreciate the feedback you give us in that survey. It helps guide us to improve the rounds and to choose topics for upcoming sessions. As a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. So please let's keep them apolitical and non-commercial. Thank you for that. Just a word about data use and stewardship. The data you share with us when you register, when you answer the polling questions, when you put questions in the Q&A is all kept confidential. The data we share with John and Rick and Asper is all de-identified. And so that's an update on the data use. As John said, NETEC is a partner in this initiative. They have their own webinar series, which is terrific. And I'm just sharing the current screenshot of that webinar series. They haven't announced the next webinar, but I'm sure they'll have one coming up in the next few days or week. But they have an archive of all their prior webinars, and we'll share a link to that as well. The Association of American Medical Colleges is also a partner in this initiative. They have been updating and keeping a clinical guidance repository since a year ago, since the beginning of the pandemic. It's a great resource. We will also share a link to that in the chat and recommend you to check that out. With that, Rick, John, back to you for the crowdsourcing question, but do want to remind people also that there's an outpatient therapeutic session tomorrow on monoclonal antibodies, and we'll share a link to that in the chat as well for anyone that would want to register and participate. John, back to you.
Thank you, Bruce. I'm going to sort of provide a little bit of explanation for this question because it was a little bit of a challenge in my mind's eye to word it to get to the point where I wanted the question to be. So this is based on either you currently are providing telehealth services or you are strongly considering or planning to provide telehealth services with your EMS agency. And in the context, what is the most significant issue or question that your organization currently has if you're providing, or that your organization currently has if you're planning on to developing a telehealth program? Which is sort of a spoiler into what we're going to be talking about today. We have talked during a number of sessions about capabilities and programs that EMS agencies are using to help take care of their patients in this COVID environment. And obviously one of those has been the development of telehealth programs. And there are a number of models that are available to be able to do that. We've got two programs that will be highlighted today with both program leadership. I need to rephrase that. With someone who's leading on the administrative and organizational side, and someone who's leading on the clinical or medical oversight side. So from the Northwell Health Center in New York, we have Jonathan Washko, who is an assistant vice president for pre-hospital innovation at the Northwell Health Center for EMS. And Dr. Jonathan Berkowitz, medical director for the Center for EMS, and oversight for the Centralized Transfer Center for Northwell Health. In addition, from MedStar Mobile Healthcare in Fort Worth, Matt Zavasky, the Chief Transformation Officer, and Dr. Elizabeth Fagan, who is the Director of Education and EMS Integrative Emergency Services with MedStar. We're thankful to all four of you for being able to join us and sharing with us your telehealth experiences and activities. Jonathan, I'll turn it first over to you.
Thanks, Dr. Kramer, and good morning to everyone. First off, I want to say thank you to Project Echo and all the sponsors. It's an amazing cast of organizations and groups, and I've been able to follow a lot of these webinars since the pandemic, and they've been very helpful. Also, I want to say thank you to all of our providers out there for the work they're doing as part of the pandemic, and for all those who gave the ultimate sacrifice. Our thoughts and prayers are with you all. So we're going to talk more about telehealth and its use in the pre-hospital setting based on our experiences with COVID. Some quick background information about Northwell Health Center for Emergency Medical Services. We're the second largest EMS provider in the city of New York, as well as the state of New York, and we're the largest healthcare system in New York State. Just to kind of give you a scope, we're actually the largest private employer in the state of New York as well. We are one of only a handful of triple accredited EMS agencies in our dispatch system with ACE, CAS accredited, and then with our air medical program with CAMES. When COVID came down, one of the things we quickly identified is what we needed to do in order to help mitigate some of the situations, and it really came down to managing risk. Now, we've been doing telehealth at Northwell since actually 2012 as part of our community paramedic program, and if you Google Northwell and community paramedics, you'll see a lot of research, peer-reviewed research that we've put out from those efforts and some of the value that it brings. But as we were developing our countermeasures and our response plans to COVID, and kind of taking what was on the shelf and realizing it may not fully work, we had to overcome and adapt. And it really came down to understanding clinical risk, operational risk, and financial risk for our patients, our responders, and our public. And our strategies really kind of were around the concept of what we called 911 pre-canting, meaning keeping people from, essentially using downstream provision of care, as well as if someone did make it into the care system, decanting if they weren't necessarily needing to be there because they were of lower acuity, or load balancing, which we'll talk a little bit more about. One of the things to kind of help put things in perspective, New York City was one of the first and probably one of the hardest hit areas in terms of the first wave last year. And this is our call volume to kind of help you understand the clinical and operational risk we were managing with that light blue line, but then also the impact of financial risk post-COVID, where you can see our volume actually hasn't come up much at all, and there's a lot of reasons for that. The nimbleness of EMS and the kind of overcome and adapt approach, plus an amazing amount of teamwork that happened here in Northwell with emergency medicine service line, many of the other service lines within Northwell, as well as our providers in the New York City metro marketplace. I see that H&H and Sinai are sponsors. We all worked highly collaboratively as part of this response and these layered countermeasures. And our primary mission, as we were flying the plane, as we built it, was to obviously do no harm. So I'm going to turn it over to Dr. Berkowitz to talk a little bit more about some of the countermeasures we were involved with before we take a little bit deeper dive into the telehealth aspects of things.
Yeah, so thanks, John. I want to echo everything you said about our colleagues who are on this call with us, and all the providers who have been who this has really been a very significant part of their professional career. So there's a lot of different countermeasures that were used to kind of mitigate the risks of COVID. We're going to talk about the telehealth program, but load balancing to some extent was preceded that, and we wouldn't have been able to stand up the 911 telehealth program without the load balancing effort. So I want to start on the next slide by just talking about what this was, because the clinical team, both from a communications agent and physician, was the same team when we stood up the telehealth program. So when we, in the first wave, we had several hospitals that were right in the epicenter and that were very hard hit. And we had to move upwards of 50 to 60 patients a day out of these hospitals. We had to find a way of doing that. And although a lot of plans called for creating alternate sites and tents, what we found was the most effective way in a large healthcare system wasn't to create new sites, but to use the existing capacity within our system for those patients. And really, much more than expected, EMS became the solution to this problem, and had a big impact. And there's a couple of things that made this a success, and I'll show on the next slide. One thing is we had to kind of align capacity throughout the system. So we used a matching market process, which is similar to what's used in organ transplant or residency match. We had a lot of facility hesitancy because although we have 23 hospitals, not all of them are used to receiving patients. So we had to really take on an incident command structure model, utilizing their chief medical officer as a major stakeholder. And we had a lot of issues to make sure we had enough transport resources, and we mitigated these in a variety of ways, including changing some of our standards of care when it comes to interfacility, working with mutual aid, and then the physician support that I mentioned that ultimately became part of our telehealth program with 911. So on the next slide, we can start to talk, John, about kind of what are the elements that are involved in our alternate pathways for delivering care from our center.
Yeah, thanks, Dr. Berkowitz. So, we've been planning for this really since ET3 came out, right, with the NOFO grant and figuring out the 911 aspects. We've all been speculating what the NOFO is going to mean. And really, when the telehealth waivers came out as part of COVID, we saw it as an opportunity to really advance what we thought that was going to mean, which was originally nurse triage, to actually the ability to take a 911 call and convert it to a telehealth visit, which I'm happy to say we successfully did back in March. So one of the things, I'm a Johnny and Roy boy. Yes, I did have the lunchbox as well as the Scott pack and the little medical kit when I was 7, 8 years old. But we've been doing telehealth since the 1960s. It's really the premise by which we've done everything in EMS. Paramedics are taught to paint that verbal picture, right, when we're talking to someone, a clinician on the other end for online medical control. And we've been doing this since day one. The systems have advanced, so now we can not just include telemetry, but obviously there's video, and there's many different platforms that the waiver has allowed us to use. And I have no financial interest in any of those, just showing you what's out on the marketplace. The other thing I think it's important to understand that we had learned as part of our telehealth program that we've been doing again with community paramedics and advanced illness management patients is because paramedics and EMTs are trained to paint that visual picture. What we found as a part of a natural experiment, and then we published in Annals on, was in fact that video enhanced the visit, but it wasn't necessarily needed for clinical decision making. And now there's some very specific things about this population. We have access to their medical information. We know a little bit about these patients in the population because it's part of the managed care group. But one of the things we found was difficulty in establishing video in the pre-hospital setting, even with some of the solutions that are out there from a connectivity standpoint. One of the things we realized very quickly when we first launched this was that we needed to mirror what happens in a physician practice. So when you go to the doctor's office, you follow kind of these bullet points on the left-hand side in terms of sequencing. And essentially, we needed to figure out how do we replicate that in the 911 environment, in the pre-hospital environment. And basically what we did, and we're fortunate enough to be tied to a large health system with all the resources we needed to do this, we turned our EMS agency into our first ever virtual physician practice in order to do this. Obviously, we don't have time to go into this, but this is in partnership with the fire department in New York and a public-private partnership, and H&H and Sinai and many other hospitals have a similar kinds of workflows. This is how we took 911 calls and got them into a telehealth visit. We actually triaged them. We were using paramedics to provide advice as well as nurses. And we had algorithms that allowed us go directly to a registration process, converting the patient from audio to video, and then doing the encounter and then billing out the encounter. So I believe we were probably one of the first in the United States, I don't know if I can claim it yet, but to actually do a 911 billable telehealth encounter in the United States. The various pieces that you need in order to accomplish this, are obviously a triage and navigation system. We work very closely with the academy as part of COVID. You need to have endpoints of care to navigate patients to. You need to be able to have a billing system that manages on your, the provider side of this, not just the EMS side. Once you are able to bill for EMS, and I saw there's some questions on that, and I think we can get into that as we take Q&A. And then obviously you need a delivery platform. Finally, we got to make sure we're not doing any harm. So we got to have a quality system. I'll hand it over to Dr. Berkowitz for the last 2 slides, and then we'll hand it back over to Dr. Kramer.
So thanks, John. So obviously we were very concerned when we set this up because this is groundbreaking and very novel. So there are 3 domains that are really important to address in terms of the quality of the care that you deliver by telemedicine, specifically to the EMS population or the 911 population. So one, from a process perspective, it's really important to make sure that there's follow-up calls that are going out to patients. We had a system to do it day 1 and then allow people to opt for day 3 and day 7. It's really important to make sure that you have a good way of sending the patient discharge instructions, standardization of those discharge instructions, including what to do, when to call back. It's really important to make sure that the patients have a way of calling back if they have a question or a concern. And it's important to be surveying your patients for the care that they receive. On the agent side, it's really important that your agents are clinicians who understand the out-of-hospital environment. We found it very helpful that our agents would go on camera with a patient. They'd be wearing their EMS uniform on camera with a patient, and that they were able to manage both physician and EMS resources. And on the physician side, we had a dedicated group of physicians that were all EM trained. And emergency medicine physicians obviously understand EMS better than any other physician, and that they were technologically inclined because this was a startup within a large health system, and they needed to be facile with technology. So the last piece I'm going to pose to the group is EMS telehealth the same as kind of regular telehealth? And since we built this program during COVID, since it started, we've taken on other non-EMS populations. And so, have somewhere to stand to say that, the environment of the patient tends to be very different. The clinical complaints tend to be very different. The expectations, a lot of these patients are calling in who get directed to us from 911 are expecting an ambulance. So the expectations are very different. The acuity is very different, as well as the likelihood of hospitalization. And probably one of the biggest differences is that a lot of the patients who come to us via 911, their access to care is very different than the patients who would come to us from another portal. So I would conjecture that EMS is not standard telehealth, and you really require both EMS operational leadership and EMS physician leadership in order to make it work. So that sums up. I'd give it over to Dr. Cromer.
Thank you very much. I appreciate all of those comments. And since we have such a smooth transition here of slides from one program to the other, oops, Matt. We'll have Matt pull up his slides and then go to questions and answers. There we go. Go to questions and answers afterwards. Matt, it's yours.
All right. Thank you, Dr. Kramer. And it is always wonderful to be part of these ECHO sessions. And it's also a little bit troubling to be part of a session that Jonathan and Dr. Berkowitz are on, because Northwell does such an amazing job with everything. If we had a vote, we would have gone first, right, Dr. Fagan? But we want to share with you what we've been doing. And just for a little bit point of clarification. So Dr. Fagan is an amazing physician who's worked with a number of EMS agencies. She is not currently our medical director. She is the EMS liaison for the physician group that we are doing the telemedicine program with. So we invited Dr. Fagan to be part of this because we felt it would be good to get the other side of the video screen's perspective on the telehealth program that we are doing here. And Dr. Fagan has tremendous insight into that because she's had to deal with these EMS providers through the entire process. So
Matt, thank you for that clarification. Just for your information, we're seeing your notes page format.
It's all it's going to show is how amazingly wonderful everybody is, right?
There you go.
So thank you for that. Matt. You would think that we would learn this by now, so I'm sorry. So MedStar in Fort Worth has been doing a telehealth program since October of 2020. And we started it initially to test the processes for our ET3 model. And we figured if we're going to rely on telehealth to do the patient navigation, we wanted to test everything ahead of time, make sure that we were doing it well, and that we picked a good provider of the telehealth services. You might understand that when we started this process, probably back in 2019, there were limited telehealth providers that were willing to do some of the things that IES has been willing to step up with. And it's worked out amazingly well. And I'll let Dr. Fagan in a second talk about their organization. But these are physicians who are emergency medicine trained primarily. They are EMS medical directors for other agencies. They are ER docs that are in the hospitals that we transport patients to on a regular basis. So they're familiar. And to that extent, they were a very logical choice, not only for us because of the familiarity and their model and their willingness to bill fee for service, those types of things, but also for our medical director, Dr. Vithalani. He knew these folks too. And he worked with them in clinical settings when he works at the hospitals. So it was a very logical choice for us to work with IES, and the program has worked very well. We started our program initially on a very small basis, and it still is small to this extent, because if we're going to find glitches in the system across the board, not only the field EMTs and paramedics introducing the concept of telemedicine to a 911 caller, getting their consent, doing the things that are necessary to even initiate the telehealth intervention, but also the back end. Are we able to transfer the patient information from the field to IES? Is IES able to get enough demographic information from that electronic exchange to be able to bill for the services that they provided? How is the QA link with data sharing working as well with our medical director, Dr. Vithalani, and his team, so that as we QA the process, we're making sure that we're able to do all of that. So our initial program is essentially now for patients who indicate that they don't want to go to the hospital. This is a relatively small cohort, as you can probably imagine, for the EMS folks that are on the webinar. And it's relatively low risk for the EMS provider. One of the things that we wanted to make sure is that as we test this process, we are not declining or encouraging people not to go to the hospital before we have all of the payers in place to pay us for not transporting them. So this is a great way to say, okay, so patients who say, I'm going to AMA or don't want to go to the hospital, we then ask them if they want the option of telehealth. We can connect them with a physician who can make some recommendations, maybe do some prescription phoning in, give other options to the patient. That's a small number of patients that allows us to test all those systems, as we mentioned, but it's also low economic risk for us because those patients probably wouldn't have been transported anyway. So we're not going to prematurely start not transporting patients without getting the reimbursement for that. I'll share with you this platform, then I'll let Dr. Liz talk about the platform and how the program works on their end. But this process was very specific with picking a provider that had the technological expertise, the things that you heard Dr. Berkowitz talking about, had some familiarity for the providers, but also had a platform that was easy to use. And IES, from the time we started talking with them to the time we actually implemented, went through a couple of platform changes that enhanced every single time. So what you see here on the screen is what the field providers see when they go through the quick process of using their smart device to connect with the telehealth provider, IES. This is Dr. Joy. She's actually the physician. I don't know if you can tell, but on the little left-hand side of the screen is actually the hand of one of her kids, because we had a lot of fun when we were doing the screenshot for the training for our folks. So she's been terrific through this process. She's sort of their technical expert. But Dr. Fagan, why don't you talk briefly about IES, how the system works on the physician side, what types of things you've seen from you and your care partners that when they're doing this service for the MedStar paramedics who are calling in, and what has been their experience?
Yeah, absolutely. So Integrative Emergency Services is a physician-led, initially emergency medicine only provider company. We now have 7 specialties and see about 1 million patient visits per year. So we've really grown, about 500 physicians, but our predominant and our first love is both emergency medicine and pre-hospital. We have a medical direction arm with 24 different departments. But we were looking at telemedicine as an option to be able to provide additional help to some of our rural partners who were wanting some assistance. And then when COVID struck, we accelerated the program quite a bit. The platform that we chose, SnapMD, it allowed us to be fairly facile. So we could be on a mobile phone, an iPad, a laptop. The platform was very stable, and it offered us the ability, when Matt asked us if to work with him with MedStar and ET3, it allowed us the ability to flex some. And so we developed a process specific for pre-hospital. And that was that in this specific one, when you log in, and it's a very simple way to log in as a patient, requires very little information. We set up an entire system so that rather than logging in as John Doe, they log in as EMS MedStar and their unit number. And that way, that allows them to make an appointment, which is the way we designed the system for the MedStar ET3 project, so that they could always get to one of our providers. And so you'll see here, looking on this left-hand side, it's an example of what MedStar is seeing. So you can see that we have a provider coming on at 7 p.m. and then the below provider, Fahad Khan, is available now. And so for these, we made these appointments every 5 minutes. And so this meant that they could log in and just simply choose a time, and that person would be available. And our providers know that they need to always be available, and they need to always be present and on the screen within 5 minutes. And then Dr. Joe, who is great, she's my technological savior. She came on at 7 p.m. that day. But the way it works for the system is you would log in, they would choose their person, their EMS MedStar, put in their unit number, and they would choose to make an appointment. And a Rolodex of our providers who are available at that time. And as the demand increases, we apply more providers there for them to be to scroll down and take a look at, and they just simply choose now. And when they choose now, it sends me a text message, as well as the provider who is on, that you have somebody who's ready to see you now. And they simply log in as a provider. MedStar is available. They pop them in, and they will give you the screen that's on the right. It's been pretty clear. I know that connectivity was something that we really worked on with Matt in the beginning, and we can talk about that a little bit. It was a little bit of our journey for connectivity. And they will pop through, and you can see both the medic, which would have been down here in and they can see us. The medic would give us a report, and I will just tell you, Matt doesn't brag about MedStar enough, but my providers, some of them, it was they had all had pre-hospital or EMS education, so they were prepared to take EMS report, interact with our medics, wanted to make sure that everyone was there. But they have done nothing but brag about the amazing reports that the MedStar medics gave. They actually said they're better reports than some of the physician handoffs that they receive in our emergency departments. All of our ER physicians are emergency medicine boarded and trained, and are all still working actively in emergency departments. So they take the report, and then they would hand us off to the patient, and we would see the patient. And we have 3 options, and it was to treat in place, to encourage the patient to go ahead and continue on to the hospital, or to determine an alternative destination, which Matt will talk about the different options they have. They gave us such an amazing set of options to choose from that we felt really comfortable giving every patient specific care. And then we would go through and we would complete the visit, ask the patient to hand us back to the medic. And then we would close the visit with the medic and let them know what our proposed plan is, get feedback from them, additional vitals or physical exam findings, et cetera. And then we would close the visit. And so it's really worked quite well. I can talk a little bit more about some of the details that go with it later, but our providers are happier to get the MedStar calls than they are for some of the standard telemedicine calls, because they're so organized and go so smoothly.
Thanks,
The
Dr.
only
Fagan.
other thing we did is if there's a connection issue, we put in an extra system so that if the connection failed, that we have a phone tree system, so that if for some reason they drop the call because of a connectivity issue, they can call an additional phone number, And it will ring down to all of the directors of this program who can all pick up and finish a call, a telemedicine visit via phone.
Excellent. Thanks, Dr. Fagan. Just to give you some of the data, and again, remember, these were patients who were initially AMA. So you'll see the number of times that it's been offered. There are some, as you saw in the outline, there's some exclusionary criteria even for the AMAs, but with the biggest sort of, I don't want to say obstacle, but the biggest limiting factor in engaging in the telehealth intervention is patient consent. Very important that you get patient consent for all the HIPAA reasons, but also for the billing reasons, because we know that IES is going to bill for the service. We're going to bill for the no transport. And the patient needs to know that not only are they agreeing to this intervention, but also there's going to be a bill for the services that they're providing. So as you can imagine, these are patients that already did not want to go to the hospital. So the vast majority of them are not willing to do the telemedicine piece as well. We know that come April 4th, when we remove the AMA limitation, and now under the full ET3 model, the medics can introduce the concept to the patient that, hey, we don't really think that you need to go to the hospital. Would you like to do telehealth, do something different? That number is going to dramatically increase. But we also know that we've tested all the systems and they work. And to Dr. Fagan's point, they can flex up staffing, and it's not going to be an epic concern once that process rolls around. You can see why some of the patients did not qualify. Again, this is Dr. Vithalani's comfort level, the training that we did for our field providers, making sure that the patients that are at risk for not only AMAing, but at risk for the telehealth intervention aren't even offered that opportunity. So you'll see some of the limiting factors there. One of the things operationally that we wanted to really track was how much scene time is this going to be adding to the patients or to the ambulances when they're on scene. So we are tracking this literally real time, and you'll notice that it only adds about 10 minutes to the scene time, which in the total context of a cycle time, if you were going to transport, what our benchmark is going to be, had that crew transported to the hospital, how much more time would have been added to the total cycle time for that crew. And it actually may be more time effective as well to do the telehealth intervention than it would be for getting the patients transported to the hospital. Economics is always a key thing. We've seen several things in the chat already about the reimbursement. As you know, under the CMS waiver, there's some additional flexibilities for reimbursement for telehealth, but even under the ET3 model, if you're going to choose to do that, then there's some telehealth reimbursement available as well. You can see how the payer mix breaks down for these patients. So we do communicate this to our payers, and they are very excited about this process because of the downstream savings related to that. In terms of COVID, our COVID non-transport protocol does not require telehealth. So we have not had to use this particular intervention dramatically with the COVID interventions. Now, our crews have used it in cases where they really have a question. It's a ready resource, and Dr. Fagan and her team at IES have been terrific in helping with many of the COVID questions that have come up for the non-transport AMAs, that kind of thing. But our standard, hey, you have a low acuity medical complaint, your assessment is stable, your vital signs are good, you have coronavirus related symptoms, we are not going to take you to the hospital. That intervention does not require telehealth. Dr. Vithalani felt comfortable enough where, and you may have heard that in a previous webinar with him. So we haven't had to use the telehealth intervention for the COVID protocol because that's really up to the medics following the protocol put in place by Dr. Vithalani. So as we mentioned, the next steps for this is the full implementation on 4.4. We're pretty excited about that. We're going to offer it to eligible payers. So not all of our payers have come on board yet with the ET3 model, but those that have, we're going to. That is a huge departure from a lot of EMS systems where we're going to make potential resources available to patients dependent on their payer. And to some people, that's heresy. Well, it's not. It's healthcare. We're going to train our folks. We've already started doing that. They're comfortable with it. EMS is healthcare, and we need to act like healthcare providers. And let's face it, our healthcare system has different resources available based on your payer source, and that's the way we're going to deal with it. So it's going to be a fun time. So with that, I'm going to turn the floor back over to Dr. Kramer for any Q&A or follow-ups. Oh, I'm sorry, Dr. Liz, go ahead.
Yeah. So I was trying to leap through the questions. So Matt's group collects the payer information. We have an HL7 interface between the two, and they send the information over, and it gets distributed to our billing company, who has been very pleased. If there's an occasional case that doesn't get through, Matt has a team on his side that has a less than 24-hour response for sending the charts over. They've been very pleased with the inclusion of all the information that's present there. And then the other thing, just when we were looking at the telemedicine model, which platform we wanted to use, we wanted to make sure that we would have access to translation. And so we can typically bring in a translator in less than 4 minutes. And we have 21 different languages that we can use. And additionally, we can add a family member in, which we thought was not necessarily as important for the pre-hospital. We originally put it in for the standard telemedicine piece, but have used it a couple times when somebody says, well, could I just get my spouse involved? And we can do the same thing. We can send them, if they can give us an email address, we can send it, and the spouse can now give the additional history, and we can treat in place. So having those two pieces, I think, was very helpful. As far as that, and then the paying piece, it's actually gone pretty smoothly. It's just really easy to work with Matt and his group at MedStar. Thank you.
This is phenomenal. I've got all sorts of questions that I'd like to follow up with, but we're going to defer to the panel and take advantage of their perspectives and questions as well. Panelists, who wants to chime up first? Dan, you got your hand up first. Please introduce yourself and go ahead.
Good morning, afternoon. I don't know what part of the world you guys are in. My name is Dan Gerard. I'm the president-elect for the International Association of EMS Chiefs. Outstanding presentations by everyone. Thank you very much. I have two questions, and I'll direct them to Jonathan, but anybody I think can kind of chime in. The first one, what were the benchmarks you utilized to determine success for the program? And then my second question is a Yui Reinhardt question. Yui trained a lot of the guys up in that part of the country. If anybody knows him, he's from Princeton. And was there a difference in utilization between populations? For example, did you see the same utility between socially and economically disadvantaged populations, people of color, and other populations? And how are you addressing those issues moving forward, and how would you define success for those disaffected populations? And again, thank you. Great presentation by everyone.
Yeah, I'll chime in and then ask others to as well. From a benchmarking perspective, I think the biggest thing, because this was so new and we were moving very quickly, was, again, first, do no harm. And if the patient didn't want telehealth, we didn't force it onto them. As well as, we built, I would say, our clinical acuity in terms of risk tolerance was extremely low in the beginning. So if you're familiar with Dr. Clausen's system, we were using card 36, but also Omega Alpha, it was kind of until we kind of got our feet wet, collecting lots of different data elements, making sure that no one fell through the cracks. So if the video connection was lost, getting a call back or sending an ambulance anyway. We did a lot of that kind of stuff in the very beginning. But some of the benchmarks Matt shared are similar things we're looking at. What's the task time? How long does it take from the time we pick up the phone until they see a physician? Because, you can get, if EMS is involved, like in an ET3 workflow versus directly the patient, the tolerance for time is always of a concern, because we don't want to keep people on scene too long and waiting to talk to a physician, or a patient waiting too long, as well as a lot of clinical pieces, to make sure that the care is appropriate, the follow-up care, visit, things like that were done. In terms of social determinants, there was a lot of issues we saw in our various populations, unfortunately, where COVID had a significant impact. And so, one of the things from our perspective is we provide services regardless of the patient's ability to pay. Number one. And number two, we don't require a video visit, because one of the things we often find is various populations have access to smartphones. Sometimes they don't, or computers or internet access. And so we want to make sure we can provide services both, via video as well as telephone. The other thing too is interpretive services, as Dr. Fagan mentioned actually our very first call was a non-English speaking, the very first call we took was a non-English speaking call. So we had to, it's New York City, right? 200 languages, I think plus. So, we were ready for that. We built for that. So those are some of the key highlights. Dr. Berkowitz, anything else from your perspective?
Yeah, I mean, Dan, I think that's a really sharp question because it's the disaffected patients or the patients that actually the service will help the most. And honestly, it's something that that my doc, who focuses on research and pre-hospital, is looking at right now, because I think that there's a lot to learn here. But I think that I'll just say practically from my experience with patients, there are a lot of opportunities to engage with patients who might be afraid or might have just think the answer is get an ambulance all the time, and that we can maybe bridge that with either like a telephone conversation with a physician. We've done that a couple times where the docs will just speak to the patient. I don't want to do a visit. Well, do you want to speak to the doctor for a minute? Okay, well, okay. Potentially even to saying to using a paramedic as a way to bridge them to what is still a more value oriented visit than going to the ER. So I think that there's a lot to be offered. The other thing that I think that's very helpful is when you do have the more you know about the patient, if you know the patient's medical history and you have access to the patient's record, and so they feel the continuity of care, and they say, "Oh yeah, hi, Miss Smith, and they know, yeah, I look, your allergies are this, your medicines are that." That people are going to be a lot more comfortable than if you just than if you're handling all the calls cold. So I think that's another important thing. But I'm open to thoughts from the MedStar team too.
Dr. Fagan?
Dan, go ahead.
So we wanted to make sure that that a patient's personal access to some type of a device that would allow them to connect with telehealth wasn't a barrier. So Dr. Vithalani and Matt, they actually provided the iPad phones with the access points and the ability to access the internet on all of their rigs. So the paramedic is connecting to us on a MedStar device and then handing it to the patient, because just from my community paramedicine, a different hat that I wear, a lot of my patients, they keep track of things just by the minute, right? And so you never want someone to not access care because they may use up the minutes on their phone that they need to be able to talk to a child or to a parent. And so Matt's team just completely took that out of the patient's worry, and this is on a MedStar device. And so it also helped us with connectivity. So I'm a big fan of that piece, because then I think we didn't have to worry about the patients having to use their own device.
Matt?
Yeah. And Dan, the accessibility issue currently under the pilot that we're doing, it's all patients, and IES has been very gracious with charity care policies, just like we are, and patients who can't pay, and they just, what's going to happen though, long-term, Dan, your question is very, very intuitive, that the patient's ability to be alternatively dispositioned is going to vary based on their payer. And to the extent that people who are uninsured or may have other economic or even clinical challenges, our window of places or our opportunity to get them to different places is going to be limited. They may still end up defaulting to the emergency department, but no one's going to be denied care. Their care will be different and maybe more customized depending on what their funding source is. And that's just the reality of today's healthcare system.
Dr. Cunningham?
Hi, I'm Carol Cunningham, the State Medical Director for the Ohio Department of Public Safety Division, EMS. Great presentations. I'm curious to see if, in terms of your liability insurance providers and physicians malpractice insurance, if there was additional costs or additional parameters. And tied into that, is there anything that, say, from a state standpoint, that states should be considering in terms of tort reform and protection for healthcare providers in this venue? And lastly, if you have time, I'm curious to see what avenues you use to communicate all these resources to the community so that they knew what to expect with telehealth. Thank you.
Jonathan, I'm going to let you think about that. Dr. Cunningham, your question is very prudent, especially when you could not have two states represented on this webinar that are different from a tort liability perspective, from a state regulatory perspective. We did run this all through our insurer, who is the Texas Municipal League. We're a governmental agency, so we're insured through that Texas Municipal League. They had no concerns with this whatsoever, because primarily all of the decision-making is resting with the physicians. So with that, I'm going to turn it over to Dr. Fagan to answer from her perspective.
So we approached our med-mal carrier, it's MedPro Group. They've been fantastic partners, and we are such a large group that when we absorbed it in, they actually did not charge. They expanded our coverage, but it did not increase our cost any.
Thank you. Dr. Kupas.
So,
Oh, I'm
And
sorry.
we do-
John-
and I'm sorry,
Jonathan?
and we had tort reform, so we weren't worried about the additional liability. We feel like we're fairly well covered.
It is
Thank you.
virtually impossible to win a malpractice suit in Texas, just so you know.
My apologies. Jonathan, did you want to respond?
I mean, it's essentially ditto, although it's New York, so we have more lawyers per capita in New York than anywhere else in the country. So yes, tort reform is a big concern, but we also had PHE waivers put in place for liability that helped with some of that. And the med-mal piece, we're part of a large integrated health system, so our med-mal automatically covered all of our involvement with this.
Yeah, just to add to that, all of our docs are credentialed as part of the credentialing packet. So it's part of their kind of their standard emergency physician responsibilities. At least the docs who are in this program are all credentialed for it. So as such, it kind of falls under the policy by the health system. It's self-insured, essentially.
Thank you. We'll go to Dr. Kupas and then go to the polling questions. Doug.
hi, Doug Kupas, an EMS physician and MIH physician in Central Pennsylvania with Geisinger Health System. As always, great presentation by these two organizations. Two questions. One is, both of you have described somewhat rudimentary video, if video is even done for these, but some telehealth systems use things that have high definition cameras or stethoscopes or otoscopes or even ultrasound capability. Are there things that you wish you had? Intuitively, I would guess maybe a higher definition camera might do more than any of those other things, since a paramedic can tell you what the lung sounds sound like and that sort of thing from a stethoscope. And my other question really to Matt, because you alluded to screening the patients for insurance, but you also said up until now you've been sort of doing it all payers. I wonder what is involved in that screening? Do you actually have people screening and looking at insurance cards, or is it good enough for them to say, okay, I have Medicare, I have this, and as long as they just ask the patient, you're going on their word? And I would assume that later you will find cases where what the patient said doesn't quite match what they have.
Dr. Liz?
So as far as the cameras, we have looked at all kinds of different things that we opted for, but to be honest, today's cell phone camera is so pristinely clear that we actually haven't had to expand to additional cameras. And I think it's just because today's cell phone and iPad cameras are amazing. So I haven't felt like we've lost resolution. We can even take photos of rashes and things like that and have very clear photos to upload into the program, into the charts.
Dr. Kupas, up until now, and I'm going to keep saying that, the decisions being made by the telehealth provider are essentially navigation decisions. So it's, can you stay home, follow up with your doc? Do you need to go to an urgent care? Do you need to go to the emergency room? That decision-making process arguably does not require a whole lot of in-depth otoscope, ophthalmoscope, listening to breath sounds or Febreze, whatever. But in another type of model where you might be using it in a true mobile integrated healthcare community paramedicine where you're doing that physician extending, then yes, definitely those things, because you're going to be basing maybe treatment decisions and prescriptions perhaps on that type of assessment, and additional diagnostics would likely be very helpful. From the economic question, yes, it'll be by general category. So Medicare, Medicaid, commercial insurance. If you've got Medicare, great. Medicaid, depending on what the legislature does, great, you're in. And commercial insurance, once we get the top three on board, which 2 of them already are, then we'll be pretty safe doing all commercial. But up until that point, we're not willing to run the risk of losing, 20, 30, 40 transports per day for agencies, for payers that aren't going to pay us. And then, of course, where are you going to send them based on the payer source? Because some of the resources available for the commercially insured are not going to be available for the Medicaid population or for the unfunded population.
From our
The only other
standpoint, oh, go
I
ahead.
would say
Liz.
the only other thing we'd say from our standpoint is we have the capacity to hook up to stethoscopes and otoscopes and things. It's just that the medics have done such an amazing physical exam that we haven't felt the need with MedStar.
Because we're going directly from 911 to the telemedicine visit, I mean, the thing I would ask for is vital signs, right? I mean, that's the simplest thing. And it's pretty common. We're all trained on, all of our docs always ask, do you have a blood pressure cuff? Do you have a thermometer? Most people now, I guess it's very small silver lining is most people have a home pulse ox now. A lot of people do that. So we do ask for that. We're very good at we even have a couple of cases where we've used some Apple Watch data. So we that's the thing that we want. I agree entirely that the camera isn't so much the issue. And honestly, to Matt's point, we're putting a lot of emphasis on thinking about how can we expand the care. So we have some of our docs are focusing on looking at, gee, what kind of things can we tell our patients to do with over-the-counter medications where we can give them medical treatment using over-the-care, because there's a lot, until you start walking through the corridors of a pharmacy and you look in the sections, there's actually a lot there that no one knows what to use for, when to use for. And so we're actually that's one of our big projects right now, is to kind of integrate that with our discharge process and to be able to give them guidance. Medical care doesn't need a prescription. And in fact, most of the times you get a prescription in a telehealth visit, most of the time the patient doesn't need one.
Thank you. We'll see about the polling questions, but there are some really interesting questions that have come up in the chat and the Q&A box. Is the telehealth conference recorded either for the EMS record or the provider's record?
So for us, the audio is recorded for the front end, but the video is, and the interaction with the physician is not.
Ours is not recorded because it's not a state requirement to do it. So it's the description of what occurred, and quite frankly, advice of counsel was don't record it.
And how is the encounter documented both on the EMS side and on the provider side? And do those match up at some point?
Yes, we'll let Liz talk about the physician side. Our documentation is on image trend. Our response number that's unique to that patient is transferred over to IES to match up with their records. Dr. Liz?
Yeah, so we get their records, and since it's a pilot, I match up the records with what the physicians have written, just because it was early on and we want to make sure that everything is going well. And we actually document right on our telehealth platform itself. And I can log in and just compare and make sure that what I'm seeing looks consistent, and it's actually been amazingly consistent. And so one on the platform and one received with the HL7 interface feed.
Yeah, for us, we integrated it's CAD, and then our patient registration system, of which we taught our dispatchers and our call takers how to use to do a quick reg as if they're, again, in an ambulatory care practice. And then that water flows into the physician documentation system, which then water flows into the billing system.
You all talked a minute ago about risk issues and medical malpractice. Has the PrEP Act that has been implemented as a result of the public health emergency impacted your practices at all? Looks like no. Okay.
No, I feel like we practice the same level of healthcare regardless. I don't feel like that we've changed anything. Matt, have we?
No, and I'll give props to IES. Dr. Kramer, one of the big things, obviously, in the CMS waiver and the PHE is the ability for telemedicine providers to bill at a much higher rate to get the emergency reimbursement. IES is not doing that, even though it could. in many cases be billed at that rate. Because they're building the economic model, they're doing the right thing. It's likely that the waivers continue, but without that high bump. So I think they're doing a great job with it.
Thank you. All right, Bruce, can we quickly go to the polling questions? We only have 5 that I think are relatively straightforward and will allow everybody 30 seconds to respond to each one of them. The first one, and you have seen the first 2 in the past. We want to continue the trending. If you're an EMS clinician, which of the following is true regarding your COVID vaccinations? First and second, want to be vaccinated and haven't yet, am not sure, don't want to be vaccinated, or not an EMS clinician. We'll go for a couple of seconds here because folks are actually responding very, very quickly. Very nice. Oh, we're still beeping up, so we're gonna, all right, we're plateauing out. Bruce? So 57% have already received both of their vaccinations. And there are still a couple of folks that either aren't sure or waiting. Thank you. Second question. EMS clinicians in our region are involved in administering COVID-19 vaccines. And while we're waiting for this to top out, I'll thank everybody who has, not only the presenters and panelists, but also the audience attendees who are sticking with us after the top of the hour. All right, we've topped out. Bruce, can you show us? So 57% are participating in administering vaccines. Almost a fifth, not yet. Great, thank you. This next one will be a little bit limited, but the EMS agencies that are currently participating in telehealth services to patients in our response area. All right. Bruce? So a little over half are not, but a fifth are, which is actually, that's larger than I expected it to be. That's very nice. Thank you. Next question. If you are providing telehealth services, is video consultation required on all patient encounters? And this will not be terribly surprising in terms of overall responses, but Bruce? So obviously the great majority of the audience is not currently participating, but of those that are, the significant majority are not requiring video consultation. And the final question, please. For those that are not currently providing telehealth, what are your plans in the next 6 months? And Rick, if we're doing these Rick and Bruce, if we're doing these webinars 6 months from now, I definitely want to see how this changes. Okay, Bruce. So we've got a fair number that probably will not be, but hopefully a fair number will be increasing programs. Great. Thank you, everyone. Really appreciate that. I'll turn Dr. Shepke. Question or comment?
Yeah, real quick, and I apologize. I'm working in the emergency operations center, so I got called away when you started your question and answer. So if it was already answered, I apologize. Thank you, by the way, fantastic presentation. Does the patients that are receiving these services, do they get a bill directly, or is it just something that's billed only to insurance? And if they do get a bill, has there been any sort of negative feedback from the patients on that?
So we bill the patient's insurance, not directly. You know, we're into this now over, well, probably 9 months. We've had zero concerns and we are generating revenue. We're not break even, but you know, we're on our way heading in a sustainable model. That's what we're attempting to do. But we don't, as of right now, we don't bill the patients directly unless there's copays or deductibles.
We bill the patient's insurance and have not been billing the patient.
All right, so we're the big old meanies. For treat, no transport, we do bill the patient, including their insurance. However, with our charity care, if they can't pay, they don't pay. And because that's what we're gonna have to do under ET3. So we just got, and we've billed for AMAs for years. So that's not a new practice for us.
And we will
Thank
be
you.
adopting that as well when he moves it. It was for the pilot that we didn't bill anyone except insurance because we just wanted to see how it worked.
Wonderful. Dr. Hunt, any final comments or questions?
No, I put it in the chat already, but I'll just like double down on, boy, if this can help us stay really focused on the patient and healthcare, connecting EMS to healthcare, what a novel concept. Just awesome.
This has been a fabulous discussion. Thank you all. I'll sort of do the round robin in the same way that we started the presentation. Any final thoughts or comments, Jonathan?
You can do this and go do it.
Thank you. Liz?
I feel the same way. I mean, it's actually really rewarding, to be honest. It's rewarding to be able to treat these patients and let them stay there or get them an alternative destination and not be just 911 ER, 911 ER. It's great. I recommend it for everyone.
Thank you. Jonathan?
Yeah, I know from our perspective, from the follow-up calls, our patients are really grateful for the service that we provide them. So it's worth it.
Thank you. Matt?
Don't go it alone. There are a number of systems in place. Reach out. Anybody, any one of us would be happy to help you with some lessons learned.
Absolutely.
Rick, did you have a comment?
Yeah, John, yeah, that's a afterthought, but it's worth sharing with our participants who are still able to hang on. So how did, I mean, you know, many of you, I'm sure, wonder how the heck we come up with these topics and, you know, where these come from. And we really try to stay really extraordinarily timely, track with the pandemic. And this one in particular, I think, just so people know how these come about, I think there was a chat item from Matt, and Matt, you know, yell at me if I chat item about some of the telemedicine issues. And I picked up on that and went back and forth with him on the chat. And that ultimately evolved to, yeah, I think there's enough here that we really need to highlight this topic in general beyond the specific issue. And then John and I talk and like, okay, let's do this one on this. So just, it's like, you know, I'm trying to like give you the behind the scenes about how we evolve this. And John, thanks for like picking up on this one and rolling with it. Cause I agree with the chat. This was a really important and good one to do. Thanks.
Thank you. And again, to our presenters, thank you, all four of you. This has been phenomenal. To the panelists, thank you for your participation. If we missed somebody, I apologize. And to the audience and to the ECHO team, again, thank you all so much. Have a great week. We will see you all next week. Thanks, everybody.